Hello, good morning, everyone. Thanks for being here. Hi, everybody. We're so glad you can join us. Please take a moment and say where you're from in the chat. We'd love to hear from you. Good morning, everybody. We'll get started in just a minute. Hi, Aria. Hello, Yolanda. Hi, Wendy. Great. We've got some folks from outside of California. We're so glad you can join us. Philadelphia. Hi, Kristen. Cheryl from California. Great. We're so glad you all could be here. Yusinia. Awesome. Yeah, we'll get started in just a minute. We'd love to hear from everybody. Just take a second and say where you're from. Hi, Rebecca. Mercy Hospital Folsom. Fantastic. Hi, Casey. Nice to see you. Glenna from Louisiana. We got a couple folks from Louisiana. Hi, Melissa. Wonderful. All right. Well, we're so glad you could be here. My name is Amy Lundstone, and I'm a project manager here with California Bridge. We're so glad you can join us today. We're really excited about today's topic. This is the third in our Innovation in Nursing series, A Perfect Match, Harm Reduction and Emergency Department Nursing. This is super important information. We're so excited to be able to share this with everyone. Joining Tana Brooks today, we have Jessica Smith from the National Harm Reduction Coalition and Josh Luftig, who's the Director of Harm Reduction Services here at California Bridge and is a PA at Highland Hospital. If you have any questions during this presentation, please put them into the chat and we'll work them into the moment, or we'll save them for the questions at the end. This session is being recorded and we have closed captioning available for those interested. CEUs are available, and we'll have the link in the chat and include it in a follow-up email. All right, well, we're so glad you all could be here, and now I'm excited to turn it over to Tana. Tana?
Thank you, Amy. I appreciate that. So first, I just want to start with each of us panelists introducing ourselves. We're very excited to cover this content today with you and share this time with you. My name is Tana. I am a nurse advisor with the California Bridge program, and I'm also currently practicing as a charge nurse in a rural emergency department. So I do this work day in and day out, and then also work on the California Bridge side too. So excited to be joining you today. Josh?
Hi, I'm Josh Luftig, and I'm a PA in the emergency department in Highland Hospital in Oakland, California. I'm also one of the founding members of California Bridge and the current director of Harm Reduction Services, which is a topic I'm very passionate about, and I'm really glad to be here. And I'm happy that you're sharing your time with us.
Thanks, Josh. And Jessica?
Hi, everyone. Thanks for being here today. My name is Jessica. I'm the Community Mobilization Coordinator with National Harm Reduction Coalition. I also live in a rural community in Humboldt County, California. My role at NHRC is to support syringe service programs and harm reduction programs across the state, specifically in rural communities. I also have experience running a syringe service program up here in Humboldt County, still active with that org, providing volunteer Hep C and HIV testing. I'm also the board chair. I'm very excited to be here with you all today.
Perfect. Thank you, Jessica. All right. So to start, I just want to mention that all of us panelists do not have any disclosures to make. And then we'll review some basics about the California Bridge program. You may or may not be familiar with them already, but so the goal of our program is to provide 24/7 access to high quality treatment for substance use disorders in all of California hospitals by 2025. And so far we have 132 hospitals that have implemented the California Bridge model so far. And so let's talk about what the California Bridge model is. Now, you may have already seen this slide if you've joined us for other presentations, but we're going to review it just really quickly so that if anyone is not familiar, you know what we're all about. So the first aspect of this is low barrier treatment. So we want to try to mitigate any barriers that patients face in order to access treatment. So that looks like a patient can check into the emergency department, and if they are in opioid withdrawal, they can get treatment quickly without jumping through a bunch of hoops. The next aspect is a connection to care and community. So we want to help facilitate patients getting connected with good follow-up care. And then the last piece is a culture of harm reduction, and that is what we are going to focus on in detail today. So with that, I am going to turn it over to Jessica.
Thanks so much. Oh, I'm unmuted. So before we start talking about harm reduction and how it's just a really great match, and how it really supports people who use drugs, I'd like us to sort of think a little bit more about substance use. And so I've got a couple of questions to get us started, and feel free to throw your responses into the chat. We can read a few of them out, but why do people use drugs? What is sort of your understanding of why people decide to use drugs? Got a response from Anthony. It says escape life. Coping, depression, to cope. Fun. Yeah, drugs can be fun. Anxiety, to relieve pain. And maybe that's a physical pain, or maybe it's an emotional, psychological, spiritual pain. Escape pain. Coping with stressors. Feel better and relief from anxiety and depression. Like the effects produced. Yeah, simple as that, right? Got something in the Q&A. It says boarding. I think maybe boredom is what that person meant. Incorrect information. Yeah, folks might not actually have any education or knowledge about drugs and what they actually do, or the potential risks. Not happy within yourself, looking for alternatives from poor pain management. Trying to fit in, anxiety and fear. Yeah, I'll let some of those keep rolling in, but I think sort of what your responses show is that people who use drugs, and the reasons that people use drugs vary, right? Substance use is very purpose driven. There's a reason that people want to use drugs, whether it's because, they're having a desired effect, they're having some sort of pain or concern, anxiety that they want to release, let go of. Accidental addiction after surgery. Yeah. Surviving homelessness, economic system oppression. Yeah. So a lot of folks, they do it to cope. They do it as a strategy to make themselves feel better, to perform better, right? Folks who have to work graveyard shifts or overnight shifts and need to stay awake, truck drivers who have to drive long distances, students who have to do an all-nighter for a test the next day, right? There are lots of reasons why people use drugs. A lot of the drugs that people use are prescribed, are legal, right? They're not actually illegal. They're doing it because they need it for proper pain management. Somebody mentioned that maybe folks aren't getting proper pain management, and so they have to seek substances that aren't legal or that aren't prescribed to them to still get the sort of care and support that they need. And so a similar question, right, is trying to understand why people don't stop using drugs. And if same thing, folks want to throw some things in the chat or the Q&A, we can talk a little bit about why people don't stop using drugs. Don't know how. Lack of support. Yeah, some folks don't know what treatment's available. They don't have somebody to support them into treatment. They like the effects. Yeah, I mentioned substance use using drugs is purpose driven, and so the effect is to feel better or to have something change, and they like that effect. Addicted physically, yeah, a physical chemical dependence. Withdrawal is painful, right? If someone's trying to numb pain or address pain, that additional pain of withdrawal can be really severe. There's changes in the body. Some people like the high. They like that feeling of being under the influence. Community stigma, yeah, fear and stigma of actually addressing their substance use, especially if they have a substance use disorder, shame around that, fear of, am I going to be stigmatized if I seek help? And yeah, some people feel bad off drugs. Again, if the point of using that drug is to feel better, they don't want to feel bad, and that might be how they feel if they stop. Depression, lack of access, economic childcare, right? If you're trying to go into treatment and you don't have insurance, or your insurance doesn't fully cover treatment and it's too expensive for you, or you have to, go to appointments and you don't have somebody to take care of your kids. People don't know what to do with themselves when they're sober. Yeah, if substance use becomes sort of this all-consuming thing in people's lives, which is not, the case for everybody, but it can happen. Your identity becomes very wrapped up in that. And also your community, right? You're the people around you, your friend circles. It's sort of maybe centered around that. And who am I and who do I have if I stop using? Fear of change, lack of confidence. Yeah, absolutely. Again, if substance use has become such a big part of your life and you're very familiar with that feeling of the safety or comfort that it provides, it can be really scary to try to change that. Denial. Yeah, some people might not feel like they need to stop, even if it has become problematic. And in the same sense, not all substance use becomes a substance use disorder. Not all substance use is problematic or harmful to the person. So they might actually just not need to stop, right? It's serving a purpose and it's not harming them in any other way. And so they're just going to keep using. Lack of money, right? Again, if people can't afford treatment, maybe there's not enough treatment programs. I can attest to that in a rural community. Our first methadone clinic just popped up over the last, I think it was almost 2 years ago now. But yeah, there's not a whole lot of treatment options in a lot of rural communities. Pets, yeah, I'm glad somebody brought up pets. A lot of folks, especially if they're unhoused, that might be their closest, dearest companion. And if they can't leave that pet with somebody while they try to access treatment, that can become a barrier as well. Yeah, awesome. So again, like you might notice that the reasons that people use and the reasons they don't stop are similar, right? They're intertwined here. And so again, just to sort of like set the stage and to really understand like drug use, right? Drug use is nothing new. It's something that humans have been doing for thousands of years. We have, archaeological evidence demonstrating humans' propensity to seek altered states of consciousness through this, the use of psychoactive substances, seeing remnants of cannabis seeds, opium poppies, magic mushrooms. People have been wanting to change their brain and, experience altered states and cope and explore for a long, long time. And even if you're drinking your coffee this morning, or, if you had a cigarette, or you ate a lot of sugar because you just had a bad day and like you really need to eat that tub of ice cream, people like drugs look different, right? We're not always just talking about cannabis or opiates or methamphetamine, right? Things that we use daily for a lot of people are considered drugs that change our brain chemistry and do that same thing, right? Of making us feel better, helping us with our productivity, helping us stay awake. And it's also really important, especially when we're providers and we're seeing people in medical settings, to really understand racial dimensions of drug prohibition, this idea of legal and illegal drugs, because it sort of ingrains in us these sort of belief systems and stigma against certain people who use certain kinds of drugs. And we're going to talk a little bit more about stigma later in the presentation. But just to sort of give you a really brief overview, this could be like a whole presentation on its own because it's very complex. But we saw some of the first like anti-drug prohibition laws in the United States. Really directed at people of color. So one of our first anti-opium laws in the 1870s were directed at Chinese immigrants. We had our first anti-cocaine laws in the early 1900s, which were directed at Black men in the South. We had our first marijuana laws in the Midwest and the Southwest in the 1910s and 1920s. And those were directed at Mexican migrants and Mexican Americans. And, we start to see the war on drugs started by the Nixon administration. And the essence of this and what we're really seeing still today is captured in a quote from an interview in 1994 with John Ehrlichman, who was the assistant to President Nixon on domestic affairs. And so he said, "We knew we couldn't make it illegal to be either against the war or Black, but by getting the public to associate the hippies with marijuana and Blacks with heroin, and then criminalizing both heavily, we could disrupt those communities. We could arrest their leaders, raid their homes, break up their meetings, and vilify them night after night on the evening news. Did we know we were lying about the drugs? Of course we did. So it's just important to sort of keep that piece in context, again, to really analyze our own stigmas, analyze our own sort of beliefs about drugs and about people who use drugs, and challenge those and realize that, you know, they've been ingrained in us as a society very early on, starting in the 1800s and more contemporary with the war on drugs, which we still see the effects today with Latinx and Black communities being disproportionately impacted, jailed for drug charges. And so that is why the California Bridge model and sort of centering harm reduction is really focusing on treatment and not criminalization. When folks come to us and they're using drugs and they have substance use disorder and they need support, we don't want to criminalize. We want to support them and offer treatment and just say, hey, how can we help you? What do you need today?
Thank you, Jessica. That is powerful stuff. And that is definitely the way we at California Bridge are very clear about addiction and substance use disorder being a medical disorder that requires treatment and not criminalization. As far as harm reduction, so what is harm reduction? And I love how active this audience is in terms of putting in the chat comments. So if we can think about what does harm reduction mean in a healthcare setting, what goes off in your mind as harm reduction? People can just put in the chat. What does harm reduction mean to you? What does that mean? Meeting people where they are, absolutely. So where people are at different places, some people are ready to jump in and quit everything and start buprenorphine. Some people are not there yet at all. They are in a totally different phase, and we want to make them safe wherever they're at. Using safely, yep. So that's people are going to use. You know, we want to stop people to, you know, it's like teenagers and sex. Like you can't just like stop them from having. Be like, just be safe. Like what you're going to do on your journey, on your addiction journey, we want you to be safe so that you make it to the next day, so that tomorrow, down the road, a month down the road, whenever it's the time when you're ready to say start buprenorphine, that you're alive to get to that step, and you don't have hepatitis C and HIV and all the harms that come with drug use, potential harms. Compassion, ensuring dignity for all, providing support to help people see another day safely and feel held in their goals. Oh my God, this is so poetic. It's so great. Reduce death by overdose. Yes. Number one, like that's the message. Encourage organic drug use. And organic drug use. I like that. I almost think I need to hear another sentence related to that. Living well while using drugs. Absolutely. It becomes so clean. You know, we get, because of the sort of cultural programming we have that Jessica covered in terms of our impulses, that, you know, the way we respond to drug use and the way we try to categorize people who use different drugs that are different than the drugs I use coffee and alcohol, and this person uses, you know, so we put people in all these different categories. And when you step away from all of that and you just want people to be safe, and you take a medical model, it's much cleaner and much easier to have these views, which you guys are just nailing perfectly. So not leaving them there, treating people with dignity, any positive change, using safely. And there's a link that I don't think I can go to at the moment. Finding community recovery support if they want it, provide resources while they have MAT treatment. Right. So, you know, that's another great point, is that when we provide buprenorphine or treatment, MAT, methadone, when we get people engaged in treatment, it's usually, you know, we know that relapse is a normal piece of recovery, and that continued use, people are going to probably, you know, so you can anticipate that. And so even though people often will hit the point where like, I'm never going to use again, I just had a horrible week and I'm out. you also want to give them a backup plan for when they use, if they do use again, that they can use safely. Safe drug use, providing Narcan, harm reduction is a bridge connecting people to services. Yes, so you guys are dead on. Another thing to think about is harm reduction is a way to keep people healthy, happy, and able to pursue their dreams. So that's kind of the sort of positive, harm reduction. And I know there's a lot of thought around even the term harm reduction, which is kind of takes it steps away from, like, if you have diabetes, do we talk about harm reduction? Why don't we talk about harm reduction in that category? So it kind of puts it, drug use and has its own language around it, and treatment has its own language around it, and even harm reduction as a term. So it is also nice to have multiple ways of phrasing it. And I like the healthy, happy, and pursuing their dreams is another kind of very positive way of framing the entire idea of harm reduction. I think we can move to the next slide. Yeah, so safer, so this is just a framework for thinking about different types of harm reduction and different sort of meeting people where they're at. So harm reduction, and this is a great just summarization. Harm reduction utilizes a spectrum of strategies to reduce the negative consequences associated with drug use, sex work, and other behaviors. So one is safer techniques, another is managed use, and another is abstinence. So these are sort of the continuum of use and meeting people where they're at, whether they want to take an abstinence approach, whether they're not ready for that, and we want to keep them safe. And kind of safer techniques and managed use are pretty similar to each other. Stigma. So stigma is what we carry with us, and our culture carries with us, and this is what drives people away from treatment and being supported and being cared for. And this slide helps us kind of break this apart into, what is stigma? Stigma is a big term, and it has a number of ideas inside of it. And one of those ideas is stereotypes. So people who are blank are incapable, fragile, dangerous, and cannot recover. So that's just the way they are. This group of people is just stuck in this place, and therefore I can just turn, look away, focus on other things and just kind of discard that entire population. And prejudice and beliefs, they're scary, shameful, and less than. So that's the ingrained biases that we bring to the table if we don't take the time to step back and unpack it and analyze it and reframe them. And then discrimination actions. So this is the way, these are some of the different ways that this comes out. So social, I don't want them to live next door, be a coworker, or marry into the family. So they're just pushed away, socially isolated. Structural, employers do not hire, support. Recovery education lacks effective supports. Health insurance doesn't provide equal coverage. So, sort of like structural racism, like this is the way the system, stigma plays out within the system and provides a structural mechanism for oppressing this population. So how does stigma impact the way you provide healthcare? So everyone think for a moment, in your workplace, what are some ways that you see stigma playing out? Like what in the healthcare setting, where do you see that play out? Like what are some examples you can think of where stigma in healthcare, if you can just put them in the comments, language, judgment. Yeah, so language is it's like language is like the computer program of our brains. So if we use language and we think in those words, we incorporate the stigma that's associated with that language right into our programming. You are an addict, so you can't have real pain. You are just drug seeking. That is basically like emergency medicine. It's like traditional emergency medicine approach right there. Yeah, it's so ingrained, and we don't even like necessarily say that phrase out loud, but unconsciously we feel that phrase. Like we just, like it's a knee jerk. Like we delays in care, right? Like so this person, we have the nice patients that we hustle right in and see, and then we have the less nice patients who that we're just going to let them wait and hope that they AMA or they just elope before they even come in. Or if they AMA, they leave against medical advice, where everyone's just like high-fiving. Yay, they're gone. Suspicion, drug seeking, no help for pain management. Right, so drug seeking. So being so you know, instead of providing just straight up healthcare, you put on a badge and you're hunting out drug seekers in this sort of cat and mouse, cops and robbers scenario where you have a very different role than anything you signed up for healthcare. Like those are the worst encounters. People are driven away from healthcare. You're not addressing the real underlying problem. And so that's really the state of healthcare in many ways, is that hunting out, you know, trying to, you know, find drug seeking and then throw those patients out rather than engaging the underlying substance use disorder. Immediate change in how people perceive patients if the chart mentions heroin, incarceration, MOUD, drug seeking. Right, the worst is when people are like in treatment and that treatment is stigmatizing. It's like this, the treatment gets stigmatized along with the disease. So true. No empathy. Complain of 10 out of 10 abdominal pain, but they don't look like it. Right, again, trying to like find the fakers, the bogus complaints. All goals are not respected. Substance use management, reducing use of problematic substances, continuing to use other drugs and drink. Right, yes, agree. Reducing people to high utilizer, frequent flyer label, subpar care, pushing own solution beliefs on people. Right, so we bring our own baggage right to the table, and we have our own ideas about what works and what this person should do. That's not science-based. So we're not stepping back and be like, what do we actually, there's an entire field of addiction that spent years like, and incredibly smart people, a whole field that has developed, and so much of general healthcare has ignored that entire field. Like we don't feel, it was never part of anyone's training. And so we're walking into these really important conversations with patients and these important situations, and all we're relying on is our instincts, which have been, as Jessica pointed out, have been programmed for political reasons in many ways. Like they're just basically all these anecdotal ideas about addiction and the role in society, and they're not science-based. So we go back, so the way we get around that is we go back to the science of addiction and understanding it as a brain disorder. Okay, and I'm gonna wrap this part up. Let's see, like recovery only plus abstinence. Right, so we wanna put people in a category. You have to start buprenorphine and stay on buprenorphine. You have to quit all drugs. Like we wanna really be paternalistic and direct the treatment program. We have our own beliefs about that rather than really stepping back, really understanding where the patient's coming from, where their goals are, and how we can help. How can I help? I'm here, I'm a resource. I have the resource of the hospitals at my disposal. How can I help you be happy, healthy, and pursue your dreams? And workplace bias, totally, absolutely. Agree. First person language. So language, again, is, you know, this is a great first step for reconfiguring the way your hospital works and the way healthcare works with this population. So person first language, this is used not just in addiction and general medicine. So you don't say like the cancer patient, you're like the person with cancer. The person is the patient, not the condition, not the modifier. And then of course, you know, the low-hanging fruit here. So terms not to use: addict, abuser, user, junkie, druggie, all these just highly, highly stigmatizing terms. And the list goes on. I won't go through the whole list. And then, you know, we use scientific terms. We use the actual term, you know, substance use disorder, alcohol use disorder, opioid use disorder. And it seems like a small thing, but it really has a big impact on the treatment team, everyone in the room, and the patient. And most importantly, they understand that you're holding this compassionate place. You understand, you're coming from a place of science and education, and not just your own bias and stigma, and bringing that to the table.
Great, thank you, Josh. What a good reminder on what language to focus on and use. I know I've been working really hard in my own practice on, you know, how can I use terms that recognize a person as a person first and values them as a person. So now let's talk about being intentional. So I want you to think about what ways can you be intentional in your own practice and thinking about the way that you provide healthcare. So I know for me, these are a few things that I'm working on. So being intentional with words and language choices. So that goes back to that person first language. And then next, being intentional with your actions and interactions. So am I modeling those word choices and language and behaviors to my team? So how am I modeling that? And also, even with patients and family, am I using terms that don't stigmatize? And am I approaching them the same way I would any other patient? Lastly, being intentional with your own personal growth and learning. So I'm excited that you all are here today to learn about harm reduction. So what are some ways that you can continue learning about this and growing in your own practice? Because we're all growing, right? I learn something new every day at work. So how can we continue this process of growing and morphing? Okay, so what does harm reduction look like in action for nurses? Well, when we treat all of our patients with respect, we're able to create a space where people who use drugs can and will actually actively engage in care because they're not fearing the stigma, judgment, and discrimination, even if they start using drugs again. I know I was talking with a patient the other day who was seeking care for, he was in opioid withdrawal, and he commented on how well he was treated. And he was so grateful that he could come somewhere where he could actually get treatment and be respected as a person. And that was just so cool to hear him say that, because that's what we're all seeking. All right, I'm going to pass it back over to Josh.
So signs, this is a great way to it's basically, so by putting signs out, another sort of simple act that can have a big impact. So if you put, I love having signs like this, like the ask us about free naloxone. There's also California Bridge signs that are, struggling with pain pills and heroin, ask about buprenorphine, addiction stops here, the naloxone signs, the harm reduction signs. The signs that you put up in key areas, which would be the ED lobby, the triage desk, the treatment areas, bathrooms, and you can just often you can just put these up. Like there's like the ER in many places is a unstructured enough place that you can just print something out and tape it up. Or you can go the formal route and get permission and do whatever. I trust you all to work within the environment as you know it. But the most important thing is the message that transmits. So when you're a patient, you see these signs, it instantly tells you that this place is different, that it is going to understand you, is speaking your language, and it's going to help you get the help you need. So with the California Bridge model, with low barrier to treatment, a connection to care and community, and a culture of harm reduction, we've found that with this model in place, for every 10 patients in the emergency department with opiate use disorder, 6 are going to receive treatment, and 4 are going to engage in follow-up MAT care, which is a phenomenal number. When you look at the traditional model, you only get 1 in 10 that are going to actually engage in follow-up MAT care. So the model works, giving buprenorphine, offering buprenorphine right in the ED, all these things, having substance use navigators, all that stuff is amazing and really pushes those numbers up and saves lives and improves lives. That being said, there's, when you meet people where they're at, there are plenty of people who still are not ready for all that. But the goal is that everyone will hopefully get take-home naloxone. So we want to, whether you're on board, you're going into treatment, or you're not ready to take all those steps, you're not ready for buprenorphine, anything like that, everyone should get naloxone, because that's the antidote that's going to save the life of people who are exposed, in this high risk category. And one of the things that I don't think the people on this call have this concern, but it's something that as you roll out these harm reduction projects, it's like, wait, are we encouraging risk behavior? What are we doing here? Are we enabling drug use? Like, are we like like a paraphernalia distribution site? Does naloxone cause people to use more drugs? Or are they just going to use drugs and then they know they're safe because they have naloxone around? And it's absolutely not true. So people who use drugs, who reverse overdose with naloxone, do not use more opioids after receiving kits. That has been researched. If scientifically, that's the answer to that question. And it makes sense. It's it's like very much like a seatbelt or a bike helmet or a condom. These are things that are just common sense interventions to increase the safety and well-being in our community. And how do you get going? So anytime you are starting a new project, there's hurdles to overcome. There's institutional inertia. There's people who have different, you've got your pharmacy, you've got nursing, and naloxone is no different. Like, you have a lot of stakeholders who are delivering healthcare, and they need to know exactly what you're doing with this new program. And what we've done to help with that process is create the guide to naloxone distribution. So there's a QR code, you can point your phone at it. A ton of work has gone into this. It's been reviewed by the Department of Healthcare Services and approved by DHCS for us to post. So everything has state approval that's in that guide. And that's where you can start to share that guide with the stakeholders and the decision makers in your healthcare system to get this going. And this is a pretty comprehensive toolkit that gets you from A to B, from having no program to having all the templates and all the resources you need to be starting to give out naloxone for free that's provided by the state of California. And you can have an amazing life-saving impact in your community.
Hey Josh, it's Tana. Wendy would like to know, does California Bridge encourage naloxone for all patients with opioid use disorder? My organization encourages naloxone for post-overdose patients, but I want to drive naloxone for patients with OUD.
Oh my gosh, yes. So not only that, and this is covered in the guide too, so you can help, often you'll be out there and you'll feel like a lone wolf, like, why are we having all these restrictions around naloxone? And in terms of just post overdose, and you're like, what about prevention? What about all the people who are at risk every day who are using opioids? And what about the people who are using stimulants that are now contaminated? So the meth is now contaminated with fentanyl. These people are overdosing. So really, anyone who's using any substances from the street, anyone who is on prescribed opioids, so once you start to actually step back and look at the entire number of people who should be getting naloxone, it's like half the ED population. It's a huge number. And that's why this kit is set up. The guide is designed to be a high volume, low barrier process so that you can give without overburdening the ED staff, who's very busy and doesn't have time to start a whole new project. They can this entire thing, everything in the toolkit is like, the log sheets are super simple. They take like 2 seconds and then you hand out the kit. The instructions to train a patient take like 30 seconds. It's all really, really easy so that it's not burdensome to the healthcare system. And that's partly, I think, maybe some of that restrictions around, let's just give it to people post overdose, is around like, we don't want to overburden the ED staff. I'm not sure what drives that. But this is really the solution is, when you want to push down the fatality rate in your community, you have to think about big numbers. You got to think about a really simple process to do it. And everything is baked into that guide to distribution. So buprenorphine, this is an interesting, buprenorphine is like buprenorphine, all MAT or MOUD, and all addiction treatment, in a sense, is part of harm reduction. Like it is a piece of harm reduction. It's just a conceptual way to think about it. And this idea of pill in the pocket. So we have our plan A, which is that, you come in, you're like, I need help. And you're like, great, I have help. Here's buprenorphine. You got an appointment on Tuesday, and that's it. The end of the addiction's been cured. That's plan A. That is like never pans out that way. That's our hope, and that's like the ideal, the platonic ideal that sits out there. That maybe has happened for like one person in the history of humanity. But But so plan B is for when all these things fail. And we plan B is that you can always come back in and restart anytime. We have all these sort of backups to try and support people on the journey, on the long and winding journey of addiction. And buprenorphine sort of you can have buprenorphine can be in that role of the imperfect solution, the adherence to treatment. Buprenorphine as a pill in the pocket. So people share buprenorphine if they take it when they're actually they're not ready to fully quit, and then they take it when they're just in withdrawal. That use of buprenorphine, similar to taking flecainide for AFib when you feel your symptoms and you take it, that is actually has a incredibly beneficial, because what we know is that people who have had exposures, even if they're not they're pre-contemplative in where they're at, they still that pre-contemplative exposure to buprenorphine leads to increased later adoption, later enrollment in treatment programs and retention in treatment programs. So that's where buprenorphine can fit in sort of the harm reduction model.
Thanks, Josh. So yeah, so far we've talked a lot about harm reduction techniques to keep folks alive, to aid in treatment, to aid in some of those withdrawal symptoms. And then, maybe you might get somebody who comes into the emergency room and they're not interested in any of that. Maybe they'll take the naloxone, but they're like, I don't want to use bupe. I've had a bad experience with it. I'm just not ready for whatever reason. But we still want to keep people safe and alive. That's what harm reduction is all about. So there are some tips that you can tell folks or ask them more appropriately if they know about safer drug use. Would you like some tips and advice on safer drug use? What do you already know about using more safely? And so some of those is, talking to folks about fentanyl. Say, we're finding fentanyl in all sorts of substances. Even if you don't use opiates, maybe there's fentanyl in the pressed pills that you found or that you got off the street, or in the amphetamine that you're using. So, always assume that there could be fentanyl. Test your drugs with fentanyl test strips, which we'll talk about in a little bit. And, have naloxone, have somebody nearby. So if you do overdose, your life can be saved. Going slow and using less, right? Especially for folks who have recently overdosed, who have recently come out of treatment, who have recently come out of jail. Those people are at a much higher risk for overdose. So, really encouraging folks to go slow, do a test shot, use less. You can always use more, you can't use less. Using a different route, right? Again, there are sort of different risks with different types of routes of use. And so if somebody is looking to change their substance use, they're not ready to quit, but they're like, I want to switch to something that's a little safer or has less risk. You can talk about smoking or snorting instead of injection. If somebody's coming in and they don't want to stop injecting, but they're getting a lot of abscesses, you can talk about rotating their veins and maybe trying muscling, just using different routes so that people aren't harming their body as much. Definitely encouraging people to not use alone if at all possible. But if they absolutely have to, like really using all of these other tips, right? Going slow, using less, testing your drugs, assuming that, there might be something else in there that people aren't actually expecting. And definitely whenever possible, like don't use alone, don't use behind closed doors, so that if you do overdose, somebody is there to help you. And that's where the awesome naloxone comes in as well. And definitely talk to people about rescue breaths with that naloxone. Again, the naloxone overdose prevention can be a whole training on its own. Naloxone is a miracle drug, but if someone doesn't happen to have it on hand, knowing how to give rescue breaths is really going to keep that person alive. It's going to keep their brain functioning while you're waiting on medical help.
Injection kits. So these are, this is actually a kit that we've been passing out at Highland for years now. And I'm just going to go through it. So basically there's a sharps container on the left. And so that they have a safe place to dispose of the syringes. There's some saline or water in bullet blister packs on is the next one. Then you've got the little cooker basins. You've got cotton for drawing through to basically as it uses a filter for when you're aspirating after you've cooked the heroin. And then you aspirate into the syringes, which are the next item there, and then tourniquets and alcohol press for skin cleansing. This is not the be all end all kit. There's different styles of kits that people give out. There's lots of different containers. There's like an infinite amount of containers of different sizes. I kind of like this one because it's a slim profile and kind of discreet. The other ones can be this sort of squarish and very bright red and a little hard to carry around. But if somebody's heading to, say, a homeless encampment, or they're heading to home, and they're not as mobile, they're not homeless, or they're not, whatever reason. So it's nice to actually offer a couple different styles and let patients choose. And probably the best people to pass these out, if you have in your hospital substance use navigators, they're fantastic. When they can deliver the injection kits to patients and handle that conversation and be really sophisticated in that conversation. But then again, after hours, great to set up your program where anyone can just give this to a patient. So clinicians, nursing, everyone can be involved in distributing injection kits.
Josh, Alicia's asking, do you actually have a frequent request for this kit?
That's a great question. We need to do more awareness. So ask us about harm reduction kits. Like that is a work in progress and putting more messaging out there. And we're actually setting up a syringe exchange at Highland, which is going to be the first one, I think, in the country that's an actual operating syringe exchange out of emergency department. And so we're going to have more promotion around that. So patients don't expect that. They're just not familiar with the fact the word has not gotten out that you can just get injection kits at Highland. So we offer it. I'm actually trying to remember to offer it to as many people as possible, and encouraging the substance use navigators I work to also, so it's more on our end that we're trying to push it out rather than it being a pull from the community. We want to create more of that demand. We want people to come in and ask for it and be able to even pass it out over the counter without even having patients, having people register as patients. Just pass it, be a resource, be a community safety net resource. And then this is the conversations you're going to have with people who are just wrapping their heads around syringe access. Want to know, does access encourage drug use? Are we facilitating and enabling drug use? And we're not. People, the things that drive drug use are much bigger than whether they've got sterile syringes to prevent them from having HIV and Hep C the next time they use. That, where they're at with their drugs is much bigger than that one event, than providing sterile syringes. Smoke kits. So we're looking at what the context kit. We do not have pipes yet. We are really excited to get pipes because there's been a national shortage due to supply chain issues. So what we have is basically in this blue box, or on this blue chuck, you see basically it's really simple. It's just the packet. This is an opaque bag that holds everything. This is a mouth. The rubber thing that's sort of reddish is a mouthpiece that you can put on the end of a pipe, so you don't have to have lip contact. Like if you're sharing a pipe, you can have your own mouthpiece and not contract COVID or Hep C through shared pipes. And then there's a little copper wire in there that keeps hot particles from being inhaled, and some various other small items, and then basically smoking instructions for how to use a smoking kit, how to stay safe, how to protect yourself. There's a lot of stigma around pipes. For some reason, you'll find that your staff will they'll be like, maybe because syringe exchanges have been around and they've got the message out, and there's more understanding around injection kits. Smoking kits somehow feels like, oh, I'm handing someone a crack pipe. Like, what does this mean? Like, it triggers a lot of stigma in people. I'm curious in the chat, why are smoke kits so helpful? Like, what's another great benefit when you're talking to people at smoke kits? What's a fantastic, I don't know if we have time. We're kind of having a long time. I'm going to give you the answer. So part of it is it's an amazing harm reduction maneuver for two reasons. One, people will smoke their substances. And if you give them a safe way to do it, they're not going to use a tin can and get all those paint and chemicals and these horrible things that people inhale when they do make pipes on all the time. So you give them a safe way to consume it. And the other thing is, if they're injecting drugs and they switch to smoking, that is much safer than putting a needle in your arm. So it's a great harm reduction maneuver, and that's the conversation you can have with everyone else. Next slide. So Sniff Gets, these are really simple. This is just a straw. This can be as simple as going on Amazon and getting 100 straws. I actually just bought some on Amazon, and I got the party straws. Like, they're all different, a rainbow array of colors. And then the other thing is, these are Post-it notes. That blue stack is actually Post-it notes. So we don't want people, sharing. It's the rigs. It's the, when you start to share all the apparatus around drug use, and that's gets spread and harm is inflicted upon patients. Next slide. Labels are a fantastic way to sort of maximize the impact of what you're doing. So this is a Narcan nasal spray, and on it there's a suicide hotline label that we printed out in Spanish, and the Spanish access line, deaf and hard of hearing, like all these access lines for the suicide prevention. There's a call to action on top: carry naloxone and save a life. And then on the bottom, it's a little hard to see, but there's how to access the substance there, how to get into treatment. So this becomes a little billboard that goes out in the community with every time you distribute naloxone, that also has a link to a life-saving link to help. So when people are ready to take the step towards treatment, they can access the Substance Use Navigator and get right into treatment. Test strips. So these are another fantastic intervention. They've been actually down on our list though. So fentanyl test strips are, once you've like had the buprenorphine conversation, had the naloxone conversation, and also treated their ankle sprain or whatever else is going on, then you're like, okay, oh yeah, and fentanyl strip. So, so there's a lot, and also, all the safer use, that stuff that Jessica went over on safer drug use. Like, there's a lot of conversation keeping people safe that don't involve fentanyl test strips. And that's good, because fentanyl test strips are not a magic bullet. They're just sort of piece in the Swiss cheese model of defense against overdose and disease. But they're not perfect. They're good. It takes a little training. You need to go, you can direct patients. One is, anyone who's engaging in fentanyl test strip distribution should become a little bit of an expert in that area, because there's to prepare the drugs and actually test them. That being said, they're only about 75 cents wholesale, and having the conversation around fentanyl test and testing your drugs is a fantastic way to get harm reduction conversation. So they are definitely another element of the support we provide our patients. And we, on California Bridge, hope to fentcheck.org is a great resource for getting, educating yourself and your patients. You can direct your patients to that resource for understanding how to properly do the test, the effect of methamphetamine on test results. There's different things to be aware of when you start to do fentanyl test strips to keep people safe.
Thank you, Josh. All right, so we are going to wrap this up. And as we do so, I would like for you to think about what's one way that this training will change your practice. And it doesn't have to be something big. It can be something very small, but I would love for you to share it in the chat if you're willing. So what is one thing that you are going to integrate into your practice because of this training? So is it maybe language choices? Maybe it's modeling behavior to your peers. Rebecca says, reminding me to watch my language. Awesome. Adding suicide prevention labels to our Narcan kits. Awesome. Yeah, that's a really great aspect to that. BUP in the ER and language. Following up to become a naloxone distributor. Awesome. Find out if we can put up posters in the ED. Great. Yeah, I know that's actually triggered some of our patients where I work to actually ask about what treatment options they have. Talking about safe use. Awesome. Thanks, Angie. Nice to see you here. Labels on Narcan, patient education, opening up conversation. Yes. Treating substance use as a disorder to help change and stigma. Awesome. Thank you all so much for sharing. Those are such good things to be working on. One more thing I want to just touch on before we close and open up for any last questions is just a reminder that addiction is not a moral failing. And this is a chronic disease that requires medical treatment. And so just bringing us back to that, that overarching concept, I think is very important. So, you know, I always think about that patient with diabetes that comes in DKA because they didn't follow their treatment plan, right? They weren't taking their medication like it was prescribed. So we see them every single time they come in. We're not going to deny them care and say, nope, you didn't follow the treatment plan, so sorry, you can't have treatment. That's the exact same way that we need to be approaching our patients with substance use disorder. Like whether or not they're following recommendations, they're here seeking help, we're here to help them. Wendy says, I use the diabetic example all the time. Yep, totally. Thank you. All right, so putting it all together, this is just a nice little graph that shows, you know, if we're, you know, integrating those principles of harm reduction, we're using person-first language, we're putting up the signage and offering treatment, that helps us to create a culture that's welcoming, that's not discriminatory, and that's not stigmatizing for our patients. And what the patients feel from that is safety and respect and value. And so if they feel safe coming and asking for help, we can actually help prevent overdoses, help save lives, help get people the treatment that they need. And, you know, all that comes together and provides access. All right. I would like to open it up for any last questions. I know we're closing in about 3 minutes. So are there any last burning questions that anyone has for us? Bridget is asking, can you email this to us? This has been recorded, and so you'll get an email with the link at the end. Amy, do you have anything to add to that answer?
We'll include a few of the resources that were linked and mentioned as well, and that a post-event email will go out tomorrow.
Perfect, thank you. All right. Josh, do you want to answer Rebecca? She's asking, what were the Post-it notes for in the one clip?
Yeah, so Post-it notes are, you know, people traditionally use like money, and they may share like share this whatever they're snorting with. So basically, you know, who has a dollar bill? They share the dollar bill, and then they get little abrasion mucosa of the sinus, the nasal cavity, and then they're also sharing Hep C. So if you have a ton of Post-it notes, they're infinitely cheap. And then everyone can just have their own Post-it note and share the dollar bill. The other thing is there's been feces this is just a creepy thing about money. There's actually, there's research that has found fecal on money. So I've moved to mostly paying by credit card at this point after reading that study. And so snorting that in is not the healthiest thing. So just through money is not a great thing in general.
All right, thank you. I'm going to turn it over to Amy as we close here.
Great, thank you so much, Tana. Will you click to the resources slide, please? Perfect, thank you. So we're so glad you guys could join us. Please take a minute and check out our resource page. We've got a QR code here, or you can access that through our website. Thank you all for joining, and a big thanks to the panelists for all this fantastic information. We do have technical assistance available, and we want to help you set up your programs and help you help patients. So please reach out. You can submit a formal request through the QR code, or again, accessing us through the website. And finally, join us in this adventure. There are links that'll show up in just a moment about how you can be part of this. And we really encourage you to sign up for our newsletter where we share updated information and resources. It's a great way to stay in contact with us and everything that we're doing. And this is how you can get a hold of Tana, Josh, or Jessica. So again, big thanks to all three of you for your great content today, and a big thanks to everybody who showed up and engaged in chat and who are open to this learning and incorporating this into their future practice. We're really glad you could be here today. Thank you.
Thank you.